Yeah.
Thank you very much, Professor Thana, for that very kind introduction. Although you may have seen me in several panels already, this is my first formal presentation in APACC, and I'm quite nervous here. So today I'm going to use this 15 minutes to talk about human papillomavirus or HPV and anal cancers and anal pre-cancers, and then its relationship with HIV infection, and then to talk about the prevention of anal cancers or in anal pre-cancers, which includes screening and treating anal pre-cancers lesion, as well as HPV vaccination. So for anal cancer, it is one of the 6 types of cancers which is caused by HPV. And here you can see what those 6 cancers: vaginal cancer, penile cancer, cervical cancer, oropharyngeal cancer, and vulvar cancer. And very similar to the cervix, the anus has this transformation zone, which is the area that the squamous epithelium is transitioning into the columnar epithelium here, which is the zone which is subjective to infection with high risk or oncogenic HPV types, which will then lead to the neoplastic transformation from the normal epithelium into something which is called the anal high-grade intraepithelial lesions, or anal hysteal, which is the known precursor of anal cancer. And also very similar to the cervix, the persistent infection of high-risk HPV in the anus is the strongest risk factor for the development of HPV-related cancers and precancers. And what you can see here is that this graph shows the proportion of anal cancers, which is caused by, on the left side, the 2 high-risk HPV, the most common high-risk HPV, HPV 16 and 18, which is contained in the 4-valent HPV vaccine, and it will be 90 to 95% caused by the other HPV subtypes, which is contained in the 9-valent vaccine, which is HPV 18, in beyond 16 and 18, it's 31, 33, 45, 52, and 58. And you can see that the proportion of anal cancers caused by these high-risk HPV is actually a bit higher than the proportion caused by these high-risk HPV types in other HPV-related cancer, like the cervical cancer or the vulvar and vaginal cancer. That is related to how you think HPV vaccine can be like primary prevention of anal cancer. In terms of the burden of the disease, the global incidence of anal cancer is around 1 in 100,000. And among the HPV-related cancers, anal cancer ranked the 2nd or the 3rd after penile and oropharyngeal cancers among men. And it also ranked the 2nd or 3rd after cervical and vulvar cancers in women. The incidence in Southeast Asia, as you can see on the graph on the left side, it's around 0.37 per 100,000 among men and around 0.26 among women. But who then among us are at risk of developing anal cancer? There are men who have sex with men with an incidence of 5.1 in 100,000 compared to the global incidence of 1 in 100,000, as you saw in the last slide. Women with high-grade lesions, cervical or vulvar lesions or high-grade or cancers are also at risk of anal cancer. All people living with HIV are also at risk of anal cancer with an incidence of almost 46 per 100,000 for MSM living with HIV, and 30 per 100,000 in women living with HIV. And smoking further increased the risk among people living with HIV. And the last population is the solid organ transplant recipients. There is quite a limited a number of studies on the prevalence and incidence of anal cancer or anal pre-cancers. But we can look at the studies on the prevalence, incidence, or persistence of anal high-risk HPV infection as kind of the predictor or a marker of the burden of anal pre-cancers or anal cancer. And what you can see in this slide on the left side, you will see the graph showing the the prevalence as high as almost 40% among MSM without HIV. That's high already, but it's still lower than MSM who had chronic HIV infection or who had acute HIV infection, which could be up to 60%. So among the clients in your clinic, you will see around 60% of your clients having high-risk anal HPV infection. And then to look at the incidence, so what we are more concerned here is probably not the prevalence, but the persistent infection, right? So on the right side, you will see that MSM living with HIV in our cohort in Bangkok, we found 4.5 times higher risk of HPV 16 persistent among those living with HIV compared to those without HIV. And the incidence was also higher among MSM living with HIV. Among transgender women, this is a cohort in Chiang Mai, they also found 71% prevalence of anal high-risk HPV. And then again, HIV status increased the risk of having anal high-risk HPV infection. Among women, we conducted a study in cisgender women in our PMT-CT cohort, which also showed that although only 4% of them reported having anal sex, the prevalence of anal high-risk HPV is at 11%. We got the chance to also conduct the study on anal HISIL, which is the anal precursor of anal cancer, right? Anal HISIL prevalence incidence as well. If you look at the data from the meta-analysis paper, you will see that the prevalence of anal HISIL among MSM is around, around 21.5% among MSM without HIV, and that's 29% if they have HIV. Among women, it's 2% if they don't have HIV, and it can be up to 6 to 27% if they have HIV. The graph here shows data from Bangkok, so this is Thai MSM. You can see that among MSM who were diagnosed during acute HIV infection, shown in purple on the bar here, the prevalence of anal HISIL at baseline is around 12%. You can see that it's quite similar to the prevalence of anal HISIL among those without HIV. And it is lower than those MSM with chronic HIV infection. So this shows you something that the level of immune destruction at the beginning of infection can probably have some effect or some impact on the development of anal precancers or anal cancers in the future. If you look at the incidence, you will see a different picture here, that even though you are MSM diagnosed during acute HIV infection and treated immediately, you're still likely to have a higher chance of developing anal precancer as compared to someone without HIV. So the incidence here is almost 19% among those diagnosed and treated during acute HIV infection, compared to 8% per year among those without HIV. But that is still lower than the 29% per year incidence of anal cancer among those diagnosed and treated during chronic HIV infection. So treat early, test early, treat early will also have some long-term impact on the development of cancer among people living with HIV. We also have recently seen a very beautiful data coming out from Australia from the study of prevention of anal cancer of the SPANK study, which enrolled MSM age 35 years and above, and also found an incidence of around 11% per year overall, and that HIV status will increase the incidence by 1.4 times. The SPANK study also demonstrated that there is because if we find anal precancer, we would want to treat them to prevent the progression to anal cancer. Whether that's true or not, we don't know. We just follow what have been done for the cervical cancer field, right? So the SPANK study would like to address, to answer those research questions. And the conclusion is that they think that not all anal HISIL requires treatment, because you can see the clearance of anal HISIL at around 22% 4% per year. But not everyone clears. And there was one progression to anal cancer, which translated into 0.224% per year of the anal cancer incidence. But what we can also learn from the SPANC study is that among those with anal high seal, those who are at younger age, those who have smaller lesions, or those who do not have persistent HPV-16 are more likely to clear. Then we also have the ANCHOR study, the Anal Cancer High Seal Outcomes Research study, which is a study in the US, trying to answer the same question, whether or not we need to treat anal high seal lesions to prevent anal cancer. And the conclusion is that the treating anal high seal can significantly reduce the risk of progression to anal cancer among PL-HIV. And the ANCHOR study selectively enrolled people living with HIV in order to demonstrate the effect of treating anal high seal to prevent anal cancer, if there is any effect on that. And they found 9 anal cancer cases in the treatment group compared to 21 cases in the active monitoring group, which translated into 57% lower rate of progression to anal cancer if you treat anal high seal. So how can we screen, how we can screen for anal high seal so that we can treat anal high seal? There are a few procedures that you can do here. Actually, Dr. Iskandar over there has been trained to do all of these things many years ago. I don't know if you're still doing this, but things that we can do is to do digital anal rectal examination. But this is actually considered something as a screening for anal cancer, because most of the anal high seal lesion will not be palpated when you do digital anal rectal examination. You can also do anal cytology. You can also test for high-risk HPV DNA. You can also do high-resolution endoscopy, which is the use of colposcopy machine to look inside the anal canal to identify abnormal surfaces that you want to do biopsy, which is considered the standard of identifying or diagnosing anal high seal. And then the algorithm of how you screen and how you manage abnormalities identified for screening is quite similar to cervical cancer screening, in a way that the field is shifting away from just using cytology to identify those with abnormal cytology. As you can see here, those with ASCAS results from cytology and above will be referred to high-resolution endoscopy. To the, in a way that we now would want to use more of the combined cytology and HPV testing. And as you can see in this algorithm, those with SH and above will be referred to HRA. Those with ASCAS will have this high-risk HPV testing. And if the test is positive, then you refer to HRA. If you have normal anal cytology, only those who have HPV-16 and 18 positivity will be referred for HRA. This is important for not only in Thailand, in our region, but globally, because we have very limited number of physicians or nurses who can perform high-resolution endoscopy. So if we screen everyone, refer everyone, no one will get further investigation and treatment. But if we can at least prioritize someone, then it's more feasible at a clinic level. And then how to treat anal high seal. There's no standard treatment, but the principle is just to try to remove the anal precancerous lesion, which is harder than you try to remove the abnormal cervical lesion, because the cervix is just there, sitting right there. But the anus is like very flexible compartment of the body that you cannot really fix them and try to manage the lesions. However, with that principle, we can use topical treatment, we can use surgical treatment. We use infrared coagulation as the main treatment modalities in our clinic. But the common findings is that recurrent rate is very high, and it's high across all these treatment modalities. Expectant management may not be the option that we offer to the client anymore after we heard from the ANCHOR study. Yes, but we with limited HRA availability, we may need to use the SPANC study findings to prioritize those who will need immediate referral to HRA. For example, those who have young age, who have smaller lesions, who do not have persistent HPV, you may be able to, or you may have to still do this expectant management. Screening for anal HSIL, treating anal HSIL is secondary prevention of anal cancer. The primary prevention is to prevent someone from getting the HPV infection, which is through vaccination. And long-term data from the 4-valent vaccines study shows that there has been no case of high-grade anal HSIL. So there's no case of anal HSIL among young men being vaccinated, and they still have more than 90% seropositivity after 14 years of vaccination. And in countries like Australia, in other settings where you do gender-neutral vaccination, you will also see the significant reduction of high-risk HPV in the anus, not only in the anus, but also in the penis and oral cavity as well. So that implies that it's not only reduction of anal cancer if you do HPV vaccination, but also the reduction of penile cancer and oropharyngeal cancer as well. So to conclude, we can see from all the data that we can identify certain populations who are at risk of getting anal cancer, who are MSM, women with high-grade lesions, PLHIV, and solid organ transplant recipients, and that we do have primary and secondary prevention strategies to address this problem. However, we must make these available and accessible to all people of all gender. Thank you very much.